Welcome to this webinar by IAMS. After the summer break, we thought we start again with interesting airway management stuff. And it's a pleasure to have you all here. My name is Robert Greif. I'm a professor of anesthesia and critical care medicine in Bern, Switzerland. And I'm the past president of this organization. Together with me today, we invited two speakers, Will Rosenblatt from the US and Felipe Urdaneta, also from the US in Florida, his hometown, or home state. And we decided to talk about barrier methods which possibly prevent infection by SARS-CoV-2. And the reason why we decided this, to say it very openly, together with Massimiliano Sorbello and Ross Hoffmeyer, we wrote together an article looking at all these papers coming up and all these methods on these barriers. And we thought this is important to disseminate this knowledge. So we can have our first slides showing the program. Yeah, maybe the technician can show us the first slide. Otherwise, we have planned. I would like to say only the rules of these webinars. Please don't turn on your microphones because it's very disturbing if we listen to background voices or talks. And we will have some interactions. So we will start with a survey, which is now here. So before we start all of our presentation, we would like to know who of you is using such barrier methods. And the second question is if you think that these barriers replaced personal protective equipment to help you not getting infected. So please start in clicking yes or no, and we are collecting the votes, and we will see directly after this what is the percentage people voted. So please, we give you about a minute to vote now. We are still waiting. We give you a little bit more time. I can see that people are still dropping in. The vote on these two questions, you can see the questions if you hit, and the results on the frequently asked answers. It's on the downside of your screen. You can open this to see how many. So from the people who answered, it's quite interesting. Half of the people said yes, they are using these barrier methods, and half not. So about 52% said yes. And the second question, which is really important, that only about 16% said yes, these barrier methods are replacing personal protective equipment, and over 80% said no, they are not protective, which is interesting, and we will see how this changes over the time. Good. So let's start with our first presentation, and the first speaker will be William Rosenblatt. Unfortunately, he cannot be with us because he's in clinics, but we did a videotaping of his presentation, and we will show this in a minute. Will Rosenblatt is also professor of anesthesia at Yale in the US, and he might be well known because he did a lot of work on pre-operative airway assessment, fiber optic views on the airway. And to get into this, I will share now my screen because I have to, okay. So you should see now the screen, and we start with Will's presentation.
My name is Will Rosenblatt. I'm professor of anesthesiology at the Yale School of Medicine in New Haven, Connecticut in the United States. I'm a member of the working group of the Project for Universal Management of Airways and also a member of the Task Force on the Difficult Airway of the American Society of Anesthesiologists. What I want to speak to you about is the use of intubation boxes or aerosol boxes in a situation where there could potentially be a difficult airway. Now, we must recognize that as many as 5 to 7% of airway management, which is expected to be easy to handle, easy to intubate a patient, up to 5 to 7% may be difficult. That may be as many as 1 in 20 patients difficult to intubate. And that includes a high Cormack and Lee-Haynes score, multiple attempts at laryngoscopy or delivery of the tracheal tube into the larynx, or failed intubation altogether. This may require multiple maneuvers, that is, repositioning the head and the neck, chin lift, jaw thrust, 2 and 3 hand mask ventilation. It may require an equipment change, maybe a change from direct laryngoscopy to video laryngoscopy, one type of video laryngoscopy to another type of video laryngoscopy, that is, a blade change, face mask size change, oral nasal airways, different supraglottic airways, lots of different equipment that may be involved, and assistance, a second skilled operator to help with position, 2 and 3 handed face mask ventilation, optimal laryngeal ventilation, and potentially emergency invasive airways. Worldwide, we have the publication of many difficult airway algorithms and strategies. Of the 19 major guidelines, a full 9 of them prescribe that a second operator be available. It is recognized by these groups that in a difficult airway situation, it is critical that a second operator be available. And this second operator needs to be available to aid with things like changes of equipment, head and airway manipulation, hands-on assistance. We talked about positioning and mask hold and laryngeal manipulation and invasive airways. In the following uncontrolled simulation, the participation of an assistant in difficult airway management is timed. 2 identical simulations are carried out that progress from rapid sequence induction of anesthesia to rapid oxyhemoglobin desaturation and a cannot intubate, cannot oxygenate situation that required an emergency invasive airway. Both intubation teams were aware of the plan, but the processes and procedures were chosen on their own. Whenever an assistant's hands are on the patient's airway or on the patient's airway equipment, the box around the overhead view turns red.
So this is important. Whenever the assistant helps, you will see this red box. And this is then to compare with the next video.
No entitled. You can cut him. That's okay, I'll cut that out. I'll cut that out. Okay, Emily? So in this scenario, the assistant had their hands on the airway for a total of 42 seconds. Now we'll look at the same scenario with two different operators with an aerosol box in place. Notice carefully how the second operator, the assistant, does not even attempt to remove the box. In fact, the box becomes displaced on its own, thereby causing other problems.
You can cut, by the way. Cover it if you want to cut it. You can assume it's in. You can assume it's in. Pretend it's in.
So as we see in this uncontrolled simulation, the aerosol boxes, the intubation boxes, can interfere not only with the physical help from an assistant, but also the psychological help of how do I assist my operator when the patient is enclosed in this airway box. We also don't know if by assisting that second operator is being exposed to more of the COVID particles. These are things that have not been studied that need to be studied. We don't know how much that physical box will interfere with equipment, will interfere with the ability of the primary operator to manage that difficult airway. In patients who are known to rapidly decompensate, we have to ask the question if these barriers hinder manipulations, changes of equipment, use of adjuncts by that primary operator. Do they hinder the assistance by a skilled second operator, or maybe give more exposure to COVID to that second operator? We have to recognize that over the last 30 years, since the first publication of airway guidelines and protocols, we have developed well-practiced and optimized airway care and rescue techniques when we have trouble managing an airway. And for technologies, that is the boxes that have not yet been proven to fulfill their promise of protecting the operators, should we minimize, undermine, or compromise proven PPE technologies as well as airway care? And are we willing to place the 5% at risk? Thank you.
So this was Will Rosenblatt's presentation so far, and it was very impressive to see how the second person, which is in charge to help the primary airway manager with the box, had troubles to help. You have the chance to ask questions in the meantime over the chat, and Massimiliano Sorbello is looking at questions, and as soon as there are important ones, he will come up and tell us some questions. Massimiliano, do we have some questions at this moment?
No, Tino, we don't have questions yet, but I use this opportunity to say hello to everyone, to welcome to this webinar. I invite you to follow the lectures and the discussion and to use the question and answer option just to submit questions. So they will be presented after the second talk, and there will be room for some discussion. So this webinar was an effort from our society also to involve you and to share knowledge and to encourage participation and interaction. So use this opportunity and enjoy the whole webinar. Thank you for being with us.
Okay, So if we don't have, so we will discuss afterwards some other questions. And one point we definitively have to look into was the result of Wilder Rosenblatt's presentation, this psychological impact of having boxes or other barrier methods which are supposed to help us in a moment of a difficult airway. With this, I would like to invite Felipe Urdaneta, who is also professor of anesthesia based in Florida. He was assigned recently as the new chair of the Society of Airway Management in the US. And Felipe, you are going to share your screen and show your presentation.
Absolutely. Well, before or while I'm doing this, I would like to congratulate you for doing this, and I would like to say hi from a distance to all the people that are hearing this, and I hope you're seeing my screen now, and so I can get started. And so I think it's basically, for me, it's been, for all of us here, it's wonderful to be here to discuss on one thing that has defined the whole year, and maybe will define for a long time to come the things that are here. This basically, who has not been affected by this issue of coronavirus? So if you're here, it's because I know you're in the same boat as we are, and we're already in September. That means month 9 of this thing. And I would like to, before I get all going, I would like to basically remind you that just in the US alone, all of us here that are participating in this, we're all healthcare workers. And just in the US, there's been 162,000 plus healthcare workers that have been infected by coronavirus. And unfortunately, as of yesterday, actually, 710 have died. I don't know in your respective countries. I know we have people from all over the world, from different areas of the world. But this is something that is basically very concerning to me, and that's kind of my interest and why I have been interested in this from the moment that the pandemic was, or that the imminent infection was announced. So that's the thing.
Felipe, my question is now, how did this happen that these barrier methods or boxes became such a topic, and lots of studies, proposals on different ways to use them popped up immediately, and still there, every week you can read a new suggestion to use it?
Sure. But I would like to, the first of all is that a lot of news, but not very many studies. So I would like to correct that. That's one of the drawbacks of the thing. And I think we have to think about how we have come up to this point. Again, month 9 or September, as we are in many areas, and I know that you have been affected, so have I, by the second wave. So we have to start thinking how methods like this became kind of so prominent and important. And I think when I think back and I put myself in the shoes that I was wearing around February and March, is, well, there was definitely a risk, and we still have it, of course. Now it's the same risk, but in a different way form. And I don't know about the areas where you were working. In my area, there was a lot of needs for PPE. We were not prepared, number one, and we did not have enough. That was a major thing that affected this. And so basically, there was not only the need, but availability was also very scarce. And I remember, for example, that not everyone in the hospital had enough, for example, simple things like N95s, gowns. Poppers were a thing that we had seen before with Ebola, but never had used before. So it's not surprising that basically then methods such as this one were thought to be kind of the answer to the prayer, to kind of protect us doing kind of high risk procedures such as airway management is, and specifically and I don't know if you noticed, but even Will in his recording called it intubation boxes, because that's what was assumed that was the most important thing that they were used for. It was just for mainly intubation. So by thinking that we had kind of a shield, a barrier from the distance, even physical separation was going to be kind of the answer, so that we will not become part of the statistic of becoming a healthcare worker. So that was how things came about. And I think that because of lack of information, all of a sudden then proliferated. I remember locally how all of a sudden over a weekend, we had 3 already different boxes that we were testing. Now, for us, fortunately, the testing did not take long, because after the first week of testing, we knew that this was not going to be a viable solution for a variety of things, but mainly adding to not just the psychological thing that Will brought up, but also it was mainly from the mechanical point of view. We could not basically conceive handling a difficult intubation, even a normal intubation, with that contraption in front of us. So that's how I think things proliferated. And if you see the things that were published, it was initially in the lay press, and there were people that were, I'm not taking anything away from them, and most of the people that were inventors and all that were not basically authorities in airway management.
Okay, so first of all, we were told that transmission happens via droplets, then aerosols came in, and now for example, the CDC stepped a little bit back. What are the recommendations? How are we? Are these really helpful? These methods, these boxes. So, what is the major point of transmission? Is the question now?
Sure. Well, it's a very pertinent question, and something that is very contested at the present time. And I think we're still being, this issue is being discussed. I'm aware that, for example, many of you have seen what happened in the last week in the United States with the recommendation by the CDC regarding whether the SARS virus or COVID-2 basically is transmitted via droplets or also airborne. And basically, bottom line is that we still do not know well, and we still have not a consensus as to how this virus gets transmitted. There's 2 major kind of theories or kind of working philosophies, and is the fact that one of them, CDC considers this a contact transmission via respiratory tract, via droplets. That means basically it is the virus, as you can see from the graphic, it basically is transported to the kind of fomites that we produce on simple things like speaking and et cetera, or coughing or sneezing. And that way is transmitted at short distances. This is why it has become so important, the issue of social distances and all that. Having said that, the concern about the airborne, which basically does not require the close contact between the person that's infected and the other person that gets infected, has become also a potential contested type of issue. And at this point, we don't know. There's not uniform consensus between the epidemiologists, the physics that know about aerosols, and also by infectious diseases as to how this virus is perhaps best transmitted. What we know now is that close contact is perhaps the most important thing. They've actually compared it to measles virus that has higher basically higher chance of becoming infectious if you come in contact with somebody that has measles. And they actually claim, the people that do not think that this is aerosol transmitted, airborne transmitted, I'm sorry, is basically saying that it's not as infectious as the measles virus. But I don't know. I'm still very concerned about this, and by the fact that we don't have at this point a consensus as to how the virus is transmitted. What we do know, and what basically the small amount of research that we have, is that the survivability of the virus depends on the size of the fomites that are produced by the infection patients and then basically us as healthcare workers can become infected by that.
Okay, so there's some uncertainties, and then this leads to my
Sure.
next question. How are these boxes? These boxes are firstly, as you said also before, Willa Rosenblatt said it, they were promoted for intubation, but aerosol generating procedures, if we still think this is an aerosol, during airway management is far more than only intubation. So how do we see these
Sure.
stereo methods, either intubation, but there's far more around this.
Absolutely. So I think going back is there's been several studies that show that basically if you tag the patient's secretions with fluorescein, then you can basically see that the healthcare worker gets also transmitted those fluorescein type of stains. That's the concerning thing. That's why we wear PPE. That's why we're so compulsive about it. And basically in this slide, you can see the difference in size of droplets and aerosols. And what's been concerning as well, before I answer fully your question, is that these aerosols can be remained alive. The virus has been detected alive in most of the studies, although not all of them, up to 3 hours, but some of them have detected it afterwards. That means it remains alive. Now, in terms of the virus itself, I think it's basically larger than, for example, hepatitis C and the same size as HIV, but obviously much smaller than Staph aureus. And it seems to be well suited to be transported in fomites. So what your point exactly is that another thing that we have used a lot is the concept of aerosol generating procedures. And I think the number one that we focused initially was on intubation, but as you say, and you bring up the point, it's also not just intubation, it's also extubation and other maneuvers and things like tube exchanges and bronchoscopy are also aerosol generating procedures and are equally important, if not more important than intubation for the potential transmission of the virus. And I think, for example, Max also has an interest, same as I do, with the issue of extubation. I think extubation is far more concerning in terms of, because it's less controlled than the intubation itself. So when we talk about this boxes or these barriers, we cannot just talk about them in the context of intubation. We have to think about airway as a whole, and it's far more complicated than simple intubation.
Okay, so this is an important issue. So the next issue is there are a lot of these boxes out. People are doing this on their own, they buy it somewhere. Is there any way, is there any approval from any authorities? Because usually I consider this like a medical device. Is there any authority who is saying, yes, use it?
Sure. And that is very, very important question. This was in the rush that we had in terms of the medical management of these patients. I think that most of this procedure, this devices when exempt. For example, in the U.S., obviously we have to deal with an entity called the FDA, or Federal Drug Agency, FDA, and so. The important thing is that, and before I answer this, I think I would like to go back to this later and answer you this, is the fact that in August of 2020, I went one more, excuse me. In August of 2020, the FDA declared that these devices were no longer approved by the exception that was granted by the government in the rush of actually dealing with the coronavirus problem. And in fact, the only ones that are recommended, or basically the FDA says that you can use, are the ones that you can actually, besides having the box itself, is having negative pressure suction, or some kind of device that you can suction the secretions from the patient. And the reason for this is that while we're basically, you can tell that we're all airway enthusiasts and experts here because we're focusing on the difficulty of airway maneuvers, but we have not discussed the potential of infection after the removal of the box itself, after it has been used on a patient. And that's something that is very concerning. So basically nowadays, in minute, I don't know which minute I am in terms of here, is we already basically debunked two things, which is number one, it makes airway management much more difficult in terms of dexterity and all that, but also it's doesn't actually not only decreases the protection, but also increases the potential for infection when you remove the box after it has been used. So as August of 2020, things have been, as people report all over the country, have been collecting dust in some corner over there because they're less and less are being used at the present time.
Okay, so to summarize this maybe, so what is missing? What do you miss in all this? What would you like to see in the future? Having these boxes or barrier methods not even on the market, but people are using this. What
Sure.
should we do now?
I think this is a lesson learned about how medical devices, or as you pointed out, the devices need to be introduced into airway management. When they lack the proper, when they don't come from authorities, number one, in airway management, and number two, when they have not gone the adequate scrutiny, we need to be basically very skeptical of how we use it. I think one of the things, and one of the message that I want to leave here is, I think back in March, perhaps the issue of the boxes became part of frenzy, part of what we call now infodemia. And basically we had a lot of things, there was too much noise, et cetera, so they make sense. But now in month number 9, when we're ready for the second wave, we know now that they're not as, they have not been quite tested, they have not been quite simulated, there's not enough data to support their use. And there is some data that, in fact, it actually cause more harm than good. Another issue that we have to address is not only does the helper have difficulty accessing you or reaching you or helping you, but you can also damage your protective gowns as you're putting your hands in and out. And every time you introduce one device in the process of handling the airway, then there's more chance of infections as well. So I think that what we have to do is not exactly do anything different. It's just do what we were always doing, basically introduce it, but introduce it first in normal patients, then simulated patients, and have some data to see if we can use it on the real thing. I think by not doing this with these boxes, now we're seeing that perhaps it was basically they were not as good as we thought they were. And I think that I want to kind of describe it with a graph that I want to show you. And I don't mean this lightly, and I do not make, but this is like this shoes. What's the point of having shoes to protect, umbrellas to protect your shoes when it's going to rain if you know you're going to get wet? And that, to me, that's exactly what these boxes are.
Okay, so thanks for summarizing all this. Now we are at the point to start the discussions and answering questions. Massimiliano, what are your first questions which came in?
Well, we have a couple of questions from the audience. So we have our colleague Monica Hervia Sanz, which is asking if maybe a lighter box would be easier to remove and may make our life easier. So the question is, if we work on engineering of these boxes, if there will be some advance with these boxes, might we expect that some of the limitation that we are seeing today could be solved in the next future? So Felipe, any idea if this could be better?
Well, I think we have seen some areas that they're in the 3rd generation of the boxes, which tells me that basically when you have that many, is because none of them have worked. And as I said before, the important thing seems to be not the box itself, but also the suction. And so to me, basically is no matter what box or barrier you use, you are going to find that your manual dexterity is going to be constrained. So I think that yes, there may be improvement. I'm not an engineer. I wish I could tell you that. But even the different boxes all of them that I tried myself, for example, I saw that my maneuvers were affected. And also one thing is, no matter what you use, you're still going to have the concern that people can get infected, and in fact, going to your face when you remove the box once it has been used on a patient. So I still think that this is going to be perpetrated, and I think the bottom line is my answer. This is my personal opinion, of course, that the boxes are not a replacement for adequate PP.
I completely agree with you. I mean, we co-authored the same paper. So basically, I think that this maybe this point with discussion didn't came out during the talk, but we need to mention, I mean, you mentioned the concept of what we call the secondary aerosolization, which is something very important, because even if these boxes may be effective with large droplets, we start to have papers demonstrating that they are not so effective with the small droplets or with the droplet nuclei. But nevertheless, what is important is that we don't know what may happen when we remove this box. And we can be careful after we finish everything with the elective situation, but if we are in emergency and we need to remove these boxes just to control the airway, I think that we are exposed to much higher risk. And we are lacking protocols for disinfection. I mean, we don't know exactly. We don't have a standard protocol for how to reuse the box. So it should be kept still, should be disinfected with one product or with one more. How can we expect to reach all the small corners or the small niches which can be in a box? So these are all open questions. And I think that what you said in the end, that until when we don't have certainties and evidence, well, we should only rely on certified PP. Tino, if you don't have nothing to add, I have another question from the audience. So our colleague Mohammad Akhtar, I hope I pronounced the name correctly, from Pakistan, he's wondering then what's the most effective method, evidence-based, to prevent viral aerosolization during intubation. And I think, I mean, this is a tough question. I can add a couple of comments, but please, Tino or Felipe, feel free to add at any time. I mean,
maybe my first thought is it's very hard to avoid aerosolization because this happens. But the question is really what is going on. If you are going to intubate a patient and he's under anesthesia, relaxed, aerosolization will be very little because they are not coughing. Nothing is coming out. Suctioning would be something. If you are going to do an awake intubation when the people are still breathing, maybe coughing, then a lot will be produced. So this, I'm not sure if this goes into this difference.
Basically, I mean, I think that the question from our colleague is really smart because he's saying that on one hand, we don't have evidence for boxes. I think that he shares this point. So he says, what evidence we have? And the answer is that probably we won't have any evidence until next month because we need data. We need to collect this data. We have a mess of data. We are in urgency. So we need rigorous analysis and methods before we have evidence. Until that time, I think that we need to use good sense or to use evidence from previous pandemic or from what we know. I think you're completely right, Tino. I mean, if we are working on an elective intubation of a COVID-19 patients, we may have everything under control. So pre-oxygenation, rapid sequence, full dose neuromuscular block, we won't have or we will limit aerosolization. Then maximize first pass success, then connect, disconnect, use filter. This is the actual evidence. And this is basically on any guideline. On the other hand, there's a few said on extubation, and Felipe raised this point, and we probably may come to the conclusion that extubation is much more aerosol generating procedure than intubation because less things can be controlled during the extubation. If I can add a final comment, I think that the only way that we have to minimize the impact of intubation is just trying to make every COVID-19 intubation elective. So work on early warning score, working on identifying these patients. So trying to go for this intubation with calm. So preparing with teamwork, with briefing and everything, rather than waiting the last minute and to intubate a fastly desaturating patient. This is maybe a good sense and evidence-based advice to minimize aerosolization during airway management procedures.
Yeah, I think also one of the things that we need to add as well that we have not addressed properly in terms of the simulations that have seen, et cetera, is that we are already changing the way we do things normally. And when we add more variability to what the things we used to do often, then we tend to make mistakes, or things tend to not go our way. I think the fact that we're wearing our basically a protective gear is already kind of a barrier in itself. So adding more variables to the thing, I think is also concerning. I think the fact of the matter is that, to me, I think there's evidence that PPE work, but I don't think that there's evidence that actually the boxes protect you from the infection itself. So to me, to answer the question of the person that asked the question is, how do we decrease the aerosolization? I don't think we can at the present time that I know of, but I think we can actually improve our chances of being fast, efficient, and decrease the amount of time that you are exposed. And I think that will be my goal when I deal with these patients.
I saw there are two people asking or commenting that when these boxes are removed, what happens to all these aerosols? Do we know exactly what's going on? One is talking about a big smoke of cloud which is released. What is this all about suctioning? Where does the material go if we suction the stuff out of the box? Any idea what's going on?
Well, I think that we can only suspect what's going on, and what we can suspect is that everything which has been collected during intubation, during surgery, and during extubation will be inside the box or the barrier. So we may only expect a lot of stuff coming out after all of this. And we shared some experience and videos with Ross Meyer. I think one of these videos was also added to our paper, but you can find them online. Adding a suction device may not be effective in removing all the aerosols or the dust, and for sure adds complexity to the system. It adds noise, it adds a device which must be placed there. You need to remove also this device. I don't think this is the way, but I see that we are igniting discussion. So there's an anonymous attendee which is adding this point of view. I mean, I think I call him anonymous attendee, probably is not recorded on Zoom, so this is how I can read it. And he or she is wondering how much aerosol is generated or released when removing the box. It is like a big smoke cloud that is being released. We don't know. There's some evidence, but you need to make a difference. I mean, this was very clear also from the very first paper from Canelli, the one which went on the New England. The aerosol box was clearly effective in stopping the large droplets. So if the patient coughs or whatever, these big drops up to 10 micron, maybe 5 micron, they can easily be stopped against the box. And this won't be a big issue because when you remove the box, they will be stuck to the box, low aerosolization. The issue is probably what we call the secondary aerosolization. So if we have all of this moved inside, when you mobilize the box, what will happen with this secretion? And this is probably a doubt. Monica Hervier-Sanz, which was the first questions, she points out that the virus concentration is a problem. And this is really a good point. And I invite Monica. There's a nice paper. The first author is called Magleby. So read Magleby. It was on clinical infectious disease. It's a very elegant paper, a retrospective study, which points out how risk of death and risk of intubation is highly related to viral load in the patient airway. So the more the patient is severe, the highest the risk of intubation and the higher the risk of complications. In other terms, means the highest the risk for airway manager. So a critical issue is how much virus can be expelled by the patient, the time of contact with the patient or with these aerosols. I mean, there's a lot of work now on the safety stop after the procedure, no? The time for air refresh or whatever. This has never been considered for the aerosol box. Felipe.
No, I think I also see adding to that question, which I completely agree with you. When we're thinking about adding negative pressure, that somebody asked, how much negative should it be? And that's an excellent question. We don't know. Those things are completely unknown at the present time. And you bring up a very important point, which is the noise issue. The noise issue is something that I think is one of the least studied things in our current issues with COVID and airway management. But I don't know if any of you that have not been in an emergency, the noise issue when you have protective gear and all that is really important, and therefore anything that adds to it, I think, is also a negative component to that. So to answer the question, I don't know how much negative pressure should it be, but I do know that that also adds to the complexity of the whole thing.
Yes, there's some more questions. Jörg Imo Bersteg, I hope his name is correct, asks, don't you think that such a box collects the aerosols but also release them concentrated when removed from the patient? So I think that you already had his answer, but it's really an excellent point and suggests that people are starting to get concerned about this. I also have a couple of questions from Dr. Vullo, I think. So first one is, do you think that in an environment other than the COVID patient arriving to the ICU, for example, OR with a doubtful patient, no difficult airway, aerosol box may be useful? So this is a good point. You have a patient which is in doubt, maybe a pending test or maybe whatever. He or she is in OR. May aerosol boxes be useful in this setting? Especially, he's asking, if combined with video laryngoscopy?
Well, once again, I think that brings up the point that's already deviating from the normal method of doing it. So when you start deviating from what you already are used to doing, that's when you start getting into issues with airway management. And maybe a lot of people have actually modified the way they do airway management. And you bring up a point that there's some concern whether there should be, well, there's more than one concern, whether you should be video laryngoscopy all the time and whether that video laryngoscopy should be on an external screen. But the whole point is that already you're modifying the way you're doing your airway management. So I think that when I go out or when I try to deal with any complex patient, the more complex there is, I try to do the same thing that I'm trained to do, because otherwise I introduce more issues, more variables that can get me in trouble. So I'm not a defender, nor I like the use of these boxes.
We have one more question. Yaxo Christian. Why don't we use plastic transparent flexible sheet instead of rigid box over the patient's upper body and head during the operational procedure and extubation? Any practice? Well, in our systematic or in our narrative review, scoping review here on BJA, which just came out, we also included any barrier enclosure system. So transparent sheets, which may be standalone or combined with a box or whatever. I think we have different issues. They are probably less cumbersome than boxes, but the risk of secondary aerosolization is much higher. You should have a technique or a protocol also to fold them. They might be combined with suction. They limit anyway your visual on the patient and also airway maneuvers, because you can get stuck or prisoned in all this plastic. And one more really important point is also that if you are delivering oxygen and this oxygen may be kept below this plastic sheet, should you be in need of a defibrillation, whatever, you don't know if you created an oxygen pouch, which could be also to increase the risk of fire. So there's really a lot of open questions. And I don't think that sheets are better than boxes. Felipe?
Well, I think that we tried the sheets as well at some point, and I can tell you that another thing that we have not discussed here today, which I think is also very important, it adds to the time of intubation. In an emergency, this is crucial. And when we're talking about COVID patients that have severe pulmonary compromise, then the longer that you spend doing the maneuvers, then the more concerning it will be for dropping saturation. So I think that you eventually will do it, and you can train yourself to do it. I'm not saying that you won't, but it will be at expense of time as well.
Yes, and Dr. Vullo adds a comment. He says that after your lecture, Felipe, he concludes that he could safely intubate a patient with personal protective equipment, but no one will dare to do it with an aerosol box, but without personal protective equipment. So he says, my safety is from PPE, the box is secondary. And this is a good point. It may add, but what we wanted to underline is that not only we should be sure that we don't add the risk for infection or whatever, we should also we need to have the certainty that they don't complicate our life. So they may be safe for infection, but they may make airway management more difficult. And this is a risk, because if we get difficulty with airway management, we increase the time of exposure, the risk of aerosolization. So the benefit that we may have from the box, we will pay anyway. I have one more question from the audience, and I think that Tino, please.
Well, I think we also have not discussed another common population all over the world, which is the obese, right? They don't fit in the box. So that's another thing. So we are already taking a high risk population and adding more risk by making it constrained into a box that may not be the best way to do it. And we saw that as well clinically.
Yes, and I think that Tino will also give us a couple of questions from the audience that he received from email, but I have one more from Roberto Guzman Nuques, and is asking the panelists, in your experience, sorry, I missed it. Okay, in your experience, what plastic barrier, might it be box or sheet, how this made your maneuvers for airway management more difficult? So do you have any clinical experience of increased difficulty when using these barriers? I think that the simulation video from Will is really, I mean, it gives us a really very similar scenario. I mean, what's happening in the simulation might happen in real life. I've been using the sheets and boxes, and I can't say that I had a specific difficulty, but my movements were limited. If I was planning to use an airway introducer, so a bougie or Frova or Ganassi bougie or whatever, that's really difficult to make it pass through the boxes or to handle it inside the box. And I think that also emergency removal would be a critical point. I don't know if you may add some more practical difficulties, Felipe.
No, I agree. I agree with you. And then the other thing is that it also impairs your vision as well, in a sense that you are now intubating into something that may reflect, the light may be reflected. We saw that as well. So it really requires you to have a screen on the outside. And I think that not everybody has a screen outside. Not everybody uses those. So I think it's quite limiting. Even think about it, even taking out the stylet, if you use a styleted tube, is difficult because you have it's not the same. You don't have the same liberty that you have when you don't have, when you're working in a fishbowl, as I call them.
Yes, and basically Will elegantly showed us that help from our colleague is limited. I think this is probably one of the biggest issue with these boxes.
I think this is a major point, that the second or third person is with use of the boxes and also with the plastic sheets. Other persons are hindered. They cannot act like without this in an emergency, or simply by helping pressuring the larynx in whatever direction. And this is a point which is often forgotten.
Yes. Tino, do you have some other questions maybe?
There was one question from the internet about pediatric use of boxes. Any experience of the use of these boxes in neonatal airway management or very small kids?
I have some indirect experience from our colleagues here in Italy. There were some attempts to develop this box for neonates. They were using mostly these plastic covers. So mostly these plastic sheets. And basically it makes some sense because the pediatric patient is basically uncooperative. I mean, you may ask an adult not to cry, but you can't stop a newborn or a baby or a child to crying or whatever. On the other hand, I think that it's the same problems, just with smaller barriers, but same big problems. Probably given the minor dimensions of kids and or children or whatever, probably some of the visual limitations of the maneuvering limitation are even more impeded in proportion. But this is my opinion, but I don't think it's far from the truth.
Felipe, do you have any experience?
I don't, I do not work in pediatrics, so I cannot tell you that, but I also do not know any of my colleagues that are currently using boxes. That's something that has not, I think that, like I said, they were abandoned pretty early. And nowadays in the US also with the FDA that I told you, they're even more so.
There was another question on teaching, because now people, residents, students have to learn airway management, and how does it affect the use of such barrier methods on the teaching?
Well,
Heavily, heavily, but I have two good news, and then I will let Felipe answer. I read a nice paper. I can't remember the name, but it was in the Indian Journal of Anesthesia. It was a kind of a first study about validating results of some online courses. So there was online teaching of the basic principle, and then small groups of colleagues in the hospital where they're already working together. So it was no matter of social distancing, and they were applying in small groups these new messages or this new way of teaching. Probably it may be, I can't say less or more effective, different effective, but I think what is important is keep going on teaching. Maybe also like we are doing, we are missing the practice, but we are giving the substance, and then everyone may practice and try to find his way. The other point is that with all these troubles and disaster all around the world, many victims and whatever, I think that there were some advantages, and one of these is that after the pandemic, probably much more people will be using video laryngoscope if compared with the past, either because they were some way forced to use them, either because hospitals finally bought them, also where they didn't have. So there's a new way, or there's a new challenge for teaching, which will be learning also to use the devices, but we have more of them. So there is probably also some good issues coming from the teaching point of view regarding the COVID-19.
Felipe?
yeah, I think, well, I think that basically I continue with my teaching at the present time. I have participated in several of these teleconferences and things like that. So a lot more is being done. Also, the theoretical component is being done like this, which I think is a great thing, and has been a great answer. I think the hands-on continues to be done. We just have to be mindful that we try to limit the number of participants in a small room, for example. But I think more than ever is the issue of importance of teaching proper airway techniques is super important, because if you think about it, every guideline that I've seen for COVID demands that the most experienced provider is the one handling the airway. But in order to continue with that, we need to bring up a next generation to make him as experienced. And the only way that we're going to do it is basically by bringing them up to speed, or else we're going to get exhausted if we continue doing these things. And
I think that we may also have learned a lesson from all this COVID-19 pandemic, that if before the pandemic, we thought that the human factor and the non-technical skills were important, I think that COVID-19 clearly showed us that they are maybe even more important. Preparedness, briefing before, teamwork. You need to consider that we are impeded in communication by PPE. There's the psychological pressure, the fear of infection, whatever. So I think that on the teaching point of view, We need probably to enforce certain messages for the non-technical skills from the teamwork, which are probably in proportion even more important than usual. Tino, if you don't have a comment on this, we have one more question from the audience.
I would say there's another question and really nice comment about the use of plastic boxes or even the sheets in advanced airway management for double lumen tubes or thoracic procedures.
Exactly.
In lateral position or whatever. So if you change this, then the use of boxes will be far more complicated.
Yes, is a question from Gerardo Cortese from Italy, is just raising this point. When you need one lung ventilation, if you're staying on lateral position, you need to change the connectors, you need to open and close the dependent lung or whatever. I think this would be much more challenging, and the box may add a lot of complexity without adding the same amount of safety. One more question here. Our friend Nabil Shalik, thanks for the webinar. And once again, Roberto Guzman Lucas, any comment about steps that you do during the extubation to avoid the contact with COVID?
Maybe let's touch this because extubation is also a very important point.
Yes.
Massimiliano.
Yes, we try to work something like this on Felipe. It's some work in progress. So we hope to come out with some nice paper also on this point, but I don't know evidence. I don't know how much evidence we may have, but if we use good sense, if we look at all of these, extubation is at highest risk than intubation for exposure to COVID-19. Because intubation is something that you can control. You decide when you intubate your patient, you can take any preventive measure, you can respect certain rules. But when the patient has to be extubated, you can't predict if he will be coughing, shouting, crying for pain, if he will be some way confused, or if there's some cognitive impairment, if he's in pain, or whatever. And all of this may generate absolutely aerosolization and larger diffusion of virus. We have less drug, less medication to control extubation if compared with intubation. We may have antiemetics, we may have antitussive drugs, but there's also recent meta-analysis showing that there's no magic bullet. So I think that once again, preparation is important. So keeping PPE on for exactly like we do for intubation, trying to use, for example, surgical mask to reduce coughing, to choose, for example, a deeper extubation and to assist the patients, which may be more controlled. I mean, there's different strategies, but I think it's hard to find a general rule. The concept is trying to control extubation the more than we could and to keep the same attention that we had for intubation.
Okay, so we are coming to a closure, an end of this webinar. May I ask both of you, Massimiliano and Felipe, what would be your take-home message now out of this discussion about barrier methods and plastic boxes?
Max, you go first.
Well, basically, I think that these are hard times, and hard times, I mean, may authorize us to go out of some rules. We might be forced to go out of some rules. If we don't have PPE, we need to invent an alternative. But I think my main point is whenever we turn into MacGyver, I mean, when we invent something or we want to get better or safer or whatever, I think that we need always to keep our good sense on. So until when we will have proof that aerosol boxes and barrier enclosures can add safety to our practice, we need to rely on PPE. And until when we want or we will have evidence that aerosol box or barrier enclosures may complicate our life or airway management, we should work on preventing any difficulty and to keeping it simple and swift and safe, to mention our colleagues from UK.
Yeah, I think from my point of view is, once again, I don't think we should be reinventing the wheel for and adding new parts to the wheel that we've never tested before when we're dealing with such complex issues as the COVID patients are. I think by keeping it simple and by doing things and trying to improve what we already have, but unless the maneuver or the device or the technique has actually some record and has shown to be promisorial in non-COVID patients, then I will not bring it up in such a complex patients, because I think that that adds more trouble than actually good. And I think the bottom line is, and I'm not going to get tired by saying it, and I'm sorry, I'm going to repeat myself, that they're not a substitute for PPE. Unfortunately, they are not. And I see there's a comment there that they were first using it for deep extubations, et cetera, but they're not using them anymore. And I think that's the bottom line everywhere in the world. Very funny, I have an anecdote that when New York was being hit with the storm of patients that they were having, they adopted the boxes for, and I think the adoption lasted about a week. After a week, we were told, and we were sent a picture of basically the graveyard of where the boxes ended up, and I think they're being recycled somewhere because nobody's using them at the present time. And I think that's the bottom line, is that they were adopted without much scrutiny or without hearing, which I think it's important. And also, they were never basically endorsed by any of the big institutions or organizations that deal with airway. And I think when you hear that, I'd rather listen to the experts, that they have a little bit more knowledge and experience. And obviously it's taken us a long time. For example, we started writing this paper a long time ago, and it obviously goes to the peer review and it takes time. But when you don't listen to the experts that deal with this every day, recommending it, have a little bit dose of respect and skepticism, because they might not be the answer to everything.
Okay, I thank you. Now we started with a survey who is using this, and now we have a second survey after all this presentation. And if the technicians come up with the question, we can ask you again, how many of you would in the future use this devices. So here's the survey. We give you maybe a minute. Do you think you will use such barrier methods to prevent infection in the future? So type in yes or no, and in more or less of a minute, we will see the answer on this.
I would bet on the answer, but
let's see. Before it was 50-50. So half of the listeners were using it and half not. And I guess we could have a look how many answered it now. So I can do this also.
I think it's on the
Good. So
secondary.
let's see the results. Will come up soon. Do we get the results from the technical stuff? Here it is. So there is some change to the no side. So about 15% switch from the yes to the no. Would be now interesting to start a discussion with the people who are still thinking they have to use it, why they are using it and how they are using it. But this can't be done at the moment.
No, so I think that this 35% represents another important point, which is those people who are still suffering the lack of PPE. I think that there's enough evidence, or there's enough good sense behind all of these probably people that are still using these aerosol boxes because they don't have better alternatives. Because I think that the PPE shortage is still an issue.
So I'd like to share my screen for the last slides. So you, I would like to have this opportunity to make you aware that it's still possible to become a member of the society, and the members of the society have the opportunity to watch the videos of the webinars via the web page. Every member has an individual account and they can go to the web page. Those who need a certificate will get a certificate if they request this by the secretary, and the secretary email address is there. It's a rather easy, secretary@earmsheadquarter.net. And the last point, I have to show you that participants who are still online have the opportunity to rate the webinars. There's a survey you can start now and give us feedback. Specifically, I would like to see which topics you want that EAMS is going to discuss during the webinars. We plan to have these webinars every second month. So the next webinar will be in November. And if we go to the next page, you can see the announcement of the next webinar on November 10th. And the topic will be the application of ultrasound during airway management. And this is going into prediction of difficulty, the use during intubation. And I also invited a colleague from India who published recently something about, it was a review, ultrasound and supraglottic devices. So please fill in the survey on how you liked it and what could we do better, and specifically which topics you want to see. And with this, thanks for attending. Thanks to the speakers also, Massimiliano Felipe, and also Willa Rosenblatt, which didn't have time to join us. And now you have the chance to fill in the survey. I guess that's it.
Good.